Good morning, everyone. Thank you very much for the invitation. It is a true honor to have this opportunity to participate in this conference as a speaker. I have nothing to disclose. So how to fit in the CAR T-cell therapy into the current treatment paradigm in B-cell ALL patients? So basically, if you have a refractory relapse patient, you may consider to pursue CAR T-cell therapy if that's available in your region. Or you may consider to try the Brino or Eno or even more chemotherapy. If you're still not able to put them into remission, then consider CAR T. After they achieve the CR from CAR T therapy, whether to pursue consolidation, allotransplantation or not, still somewhat controversial. However, recently more and more data shows some benefit. So from this slide, you can see despite a very high initial CR rate, up to approximately 90%, complete CR using the CD19 CAR T therapy for refractory relapse B-ALL patient. However, the long-term disease-free survival and OS are still need a further improvement. For pediatric patient, you can see somewhere around 40 to 50%. For adult patient, if you able have the patient achieve MRD negative CR, or if they have a relative low disease burden, and then overall are still doing relatively well with somewhere around 50% long-term OS. On the other hand, the outcome are still poor. So this is a review paper published last year. They totally put a 10 article into review. Within the red line frame is the paper actually from our institute we published in leukemia in 2017. The vertical red frame, within the red frame line, you can see the summarize the relapse rate with transplantation versus CAR T therapy alone. Again, clearly all those 5 articles indicated with consolidation allotransplantation, the relapse rate is much less. Once more, this is another 5 article paper, and the horizontal one, the within the red frame is a paper from us. We published in the Blood Advances. We put a total 110 patients. The right, the horizontal, the within the red horizontal frame is again summarize the with consolidation allotransplantation versus CAR T therapy alone. You can still again see with transplantation, the relapse rate is much less. So we recently published another paper in cancer immunology, immunotherapy. We try to find what kind of a factor associated with OS or leukemia-free survival in B-cell ALL patient who achieved the CR after CAR T therapy. This is total 231 patients by univariate analysis. The red star marked here indicated the significance, which including prior history of allotransplantation before CAR T therapy, or if a patient have a complex cytogenetic abnormality, or if they have a TP53 mutation, if they have a consolidation allotransplantation after CAR T or not, make a significant difference, and also significance, severity of CRS or neurotoxicity also make a difference. However, on age, whether pediatric or adult patient, extramedullary disease, leukemia burden, or CAR T cell infused dose shows no significant difference. We further pulled those data doing the multivariant analysis. 3 things really jump up, showed a significant difference, both in leukemia-free survival and OS. You can see the one is where the patient pursuing consolidation allotransplantation after CAR T versus just CAR T cell therapy alone, or if a patient have a TP53 mutation or not, or if they experience severe CRS or not. Those are detailed. You can see the 1-year leukemia-free survival can be achieved up to 71% for CAR T therapy plus consolidation allotransplantation versus just CAR T cell therapy alone is down to 33.3%. Again, 2 years leukemia-free survival and OS also show the two groups are significant difference and favoring the transplant group. For those patients who have a TP53 mutation, even if they receive a CAR T treatment, they still do worse compared to those people without TP53 mutation. For that 1-year leukemia-free survival, with consolidation allotransplantation, you can achieve a 58.8% leukemia-free survival. Without consolidation allo, the leukemia-free survival is down to 16.7%. So what about for those low leukemia burden patient? If their bone marrow blast less or equal than 5%, we have a total of 96 patients. We did analysis. CAR T treatment alone for those patients, you're able to achieve near 2 years survival, somewhere around 46.7%, which further increased to near 66% if the patient pursue consolidation allotransplantation. Even those patients have a bone marrow blast less or equal than 5% before CAR T treatment, many of them still have other high-risk features. So what about the safety? If you have a patient underwent the CAR T treatment, achieve the CR, then pursue consolidation allotransplantation versus a patient and when the chemotherapy achieved CR1 or CR2, then have consolidation transplantation. To compare their safety and outcome. With that question, we also had a parallel comparison from November 2015 to August 2016. We in the CAR T group, we have a 27 patients. All those are treating for refractory relapse, heavily pretreated patient. In the chemotherapy group of patients, those are chemotherapy achieved CR1 or CR2, then pursued allotransplantation. So the overall, the engraftment, especially WBC, shows no significant difference. For overall incidence of acute GVHD, the chemotherapy group patients are doing better. However, for severe acute GVHD, both groups are same. Whether patient experience severe CRS or not has no influence on their subsequent acute GVHD incidence. What about chronic GVHD? Once more, for overall incidence, the CAR T group are worse than the chemotherapy group. However, for severe chronic GVHD, both groups are same. In our patient, a majority of our patients in those studies are haplotransplantation accounts for more than 70%. So now we have 4 years leukemia-free survival and OS. You can see whether the refractory relapse patient, after they pursue CAR T, if they're able to achieve CR, then pursue consolidation, allotransplantation, their outcome can be as good as those patients that using the chemotherapy achieve the CR1, CR2, then pursue the consolidation transplantation. So they have a wonderful, both groups have a wonderful outcomes. Only difference is if a patient, what's their MRD status. If you only able to achieve MRD positive status from CAR T before transplant, they do much worse than those patients able to achieve MRD negative disease status before transplant. So what about OS and leukemia-free survival? Compare CAR T alone versus CAR T plus second consolidation transplantation for BALL patient who relapse after first transplantation, then they pursue the CAR T treatment. So if they just pursue the CAR T treatment alone, their 2-year leukemia-free survival is somewhere around 17.6% in our hands, versus if patient able to achieve second transplantation, then they're improve the leukemia-free survival up to 54.4%. So this is a recommendation from that review paper. I think it's reasonable. Let's take a look. If you have a patient achieve the CR after CAR T, then you need to assess them. You need to do assessment to see if they have any of those high risk feature, which including if they have complex cytogenetic or adverse gene, or if they have a high leukemia burden, or if they have a high LDH, low platelets before FC conditioning regimen, or if they conditioning regimen without fludarabine, or if a patient have a persistent molecular evidence of leukemia, or if they have early loss of a CAR T cell, recovering of a B cell, those patients you need to strongly consider to have a consolidation allotransplantation. If not, then you can choose continue to close the follow-up. If with the follow-up, if those patients develop MRD positive disease status, or showed recurrent or molecular recurrence even per next generation NGS study, or if they lost their CAR T persistent, then you may consider to pursue a consolidation allotransplantation. So in summary, patients with high risk feature, either pediatric patient or adult patient, you may consider to pursue the consolidation allotransplantation. Once they are able to achieve MRD negative CR or even MRD positive CR after CAR T, you can consider to transplant. Our recommendation is within 3 months, because beyond 3 months, those high-risk patients may start to show a higher recurrence rate. You may consider myeloablative regimen if possible. The role of consolidation allotransplantation should be continuously redefined with the development of novel CAR T structures and the combination therapy. We hope in the future, with the novel CAR T, the continued improvement of the CAR T therapy, patient no longer need a transplant. However, at the present time, high-risk patient, our recommendation is pursue the consolidation transplant. We are a hematology institute. Since 2015, we've been doing CAR T clinical trial. You can see each year we increase our number. Despite the COVID-19, over last 6 months, we already completed 192 patients. So all those work are teamwork. We are very proud of our team, and thank you very much for your attention.